I am Dr. P.C. Banoria, Executive President, First World Congress on Cardiometabolic Medicine, being held at Mumbai, 27-28 April 2019. And with me is Professor Mancia, who is a globally renowned cardiologist with many stems of guidelines on hypertension. Dr. Mancia, hypertension is rampant throughout the globe, including India. The problem is, how do you diagnose hypertension? Which blood pressure you should take for diagnosis of hypertension? The office blood pressure, the home blood pressure, the ambulatory blood pressure. What is the best way to diagnose hypertension?
Well, home and ambulatory blood pressure for sure provide important supplementary information, but the gold measure remains office blood pressure, because it is through office blood pressure that we have learned, thanks to randomized outcome-based clinical trials, that reduction in blood pressure is a protective measure, and that keeping blood pressure high is a cardiovascular risk factor.
What are advantages of ambulatory blood pressure monitoring? And when do you ask for ambulatory blood pressure monitoring in a patient with hypertension?
Well, the advantages are that it allows to tell you, for example, whether a treatment which has been decided covers the entire 24 hours or leaves some hours uncovered by treatment. It also has an important prognostic value, but no trials so far have been done with home blood pressure or ambulatory blood pressure. And this is a big hole in our research that hopefully will be filled up in the future.
In our country, we are having cuffed ambulatory blood pressure monitoring. So when the blood pressure is taken during the night, some of the individuals get awake, and they say it gives awake night blood pressure. The cuffless blood pressure, are they going to be available in the future so that the individual doesn't have disturbed sleep and real night blood pressure is taken?
There is still research to be done, but certainly it will be an advantage to be able to accurately measure blood pressure, eliminating cuff inflation, which, as you say, may have some disadvantages for nighttime blood pressure. Now, it seems possible also to be able to measure nighttime blood pressure through home blood pressure monitoring, which is also an additional advantage. So the future is full of promise in terms of feasibility of different blood pressure measurements that could improve the accuracy of the assessment of the risk and also the accuracy of the assessment of effectiveness of treatment.
Initial dual combination has been a historic recommendation for treatment of hypertension, indeed very useful. But the issue is, which dual combination, in your opinion, is the best, or you select particular dual combination for a particular subset, another combination for another subset?
My idea has always been liberal. That is, we have trials showing protective effect, including trials using combination treatment with different drugs. So I think having a large number of options is an advantage for the physician and for the patient. But the present European guidelines, for example, they have elected to give slightly greater prominence to combination treatment based on a blocker of the renin-angiotensin system, either with a diuretic or with a calcium channel blocker, also for pragmatic reasons, because these combinations are available in a single tablet format. And this could be an advantage for the patient because simplification of treatment improves adherence to treatment.
How do you compare CTD with indapamide? When do you use CTD? When do you use indapamide?
Well, all three diuretics have strong evidence of cardiovascular protection through placebo-controlled trials. Hydrochlorothiazide, indapamide, and clortalidone. Indapamide and clortalidone are slightly more powerful and have a longer duration of action. And apparently, because of the data from recent meta-analysis, there is no price to pay in terms of reduced tolerability. They are equally tolerable compared to hydrochlorothiazide. So perhaps from this point of view, they can be preferable. But certainly, hydrochlorothiazide remains an important historical drug because many earlier trials showing protective effect of antihypertensive treatment has been done through hydrochlorothiazide.
Indapamide is a weak diuretic, but the fall in blood pressure is much greater. What are its other actions?
The falling blood pressure with indapamide is greater than with hydrochlorothiazide. It's about 5 millimeter mercury difference in systolic blood pressure. And there are data that indapamide is a well-tolerated drug. For example, effect on lipid profile and glucose profile are very, very small, because we know that diuretics, for example, in patients prone to develop diabetes may favor the new onset diabetes. And this has been certainly less for indapamide than for hydrochlorothiazide.
The guidelines for hypertension do not discriminate between AC inhibitors and ARB. What is your personal viewpoint? Which should be combined with a calcium channel blocker, an ARB or ACE? Or they are equal? It's personal choice.
Head-to-head comparisons did not show any difference in terms of cardiovascular protection. Angiotensin receptor antagonists have an excellent tolerability profile, but ACE inhibitors are very close. And the overall evidence collected through ACE inhibitors is greater than that collected through angiotensin receptor antagonists. For this reason, recommendation to use angiotensin receptor antagonists in guidelines have a slightly lower level of evidence and class of evidence compared to that of using ACE inhibitors.
ARB has been incriminated to increase AMI in many trials compared to AC inhibitors. So what is the current status? ARB increases AMI, or what is your viewpoint?
No, I don't think so. I think there was a very old paper published in The Lancet which turned out to be not a good study. And I think all the head-to-head comparisons which are available do not show this, and even meta-analysis do not show this. ACE inhibitors, on the other hand, do have a lot of good trials, not only in hypertension, but also in coronary heart disease, of course, which are not available for angiotensin receptor antagonists.
Do you have any personal preference for any particular AC inhibitor?
I think perindopril is, for sure, the drug which has been studied more in depth because it has been used in several hallmark trials. For example, ADVANCE, which is the largest trial in diabetic hypertensive patients. PROGRESS, which is was the first trial proving reduction in the risk of recurrence of stroke in patients having a previous stroke. And then also other studies such as I can't remember the acronyms now, but there have been several studies.
What is the current status of renal sympathetic denervation after the Simplicity? Is it going to come back, or?
It went through a three-phase, great enthusiasm, big fall, and then it's up again. The recent European guidelines, what they say about renal denervation is that there is no evidence for routine use. But the evidence is good enough to stimulate further studies. And these are justified because recent studies with the control design, 3 or 4 studies after the big fall provided by Simplicity 3, they have shown that this procedure has the ability to lower blood pressure. And probably we are moving now from use of renal denervation in resistant hypertension to use of renal denervation in difficult to control hypertension. Because now with the lower target blood pressure values, perhaps in several patients, even multi-drug treatment will not be enough. So the addition, which might be given by renal denervation, could help achieving the lower blood pressure target.
The problem with renal denervation is whether it has been done correctly or not. Is there any parameter to assess that the procedure has been done? Just as after angioplasty, you see post-angioplasty, vessel dilated. So how do you find out the procedure has been done correctly?
You have touched a painful issue. No procedure, as I can say, that can ensure during the procedure or immediately after the procedure that renal denervation is effective. And we know now that denervating completely the kidney is extremely difficult because the nerves are far away in the adipose tissue outside the renal arteries. And if the procedure is extended too much, we run the risk of denervating fibers which go to other organs and have different functions, you see. So I think this remains an extremely important issue, but research is proceeding and some new data may come out in the close future.
The other issue is the mortality of a controlled hypertensive is 1.5 to 2 times that of a normotensive.
Yes.
So what are the reasons for increased mortality despite control of hypertension, and what can we do to further decrease mortality in this subset where blood pressure is controlled but they are not par with the normotensive patients?
This is a painful issue which is shared, unfortunately, by all risk factors. That is, even in apparently well-treated hypertensive patient, residual risk is high. That is, it's higher than that of the controlled population. That is, with similar age, with similar gender, and so forth. And of course, there are many possibilities. One possibility, which we cannot avoid, is that genetically, a portion of the risk is irreversible. But of course, there are several other possibilities. Better control of concomitant risk factors, better control of blood pressure variability. Now we have learned that keeping blood pressure more stable can be an additive protective factor, and several other possible possibilities are now under investigation. But you are completely right. Even well-treated hypertensive patients, and this is known since a long time, continue to have a risk which is higher than that of the controlled population.
Is frequent measurement of blood pressure may be a cause for hypertension? People measure blood pressure very frequently with the automated.
Yeah.
Can it produce hypertension?
Home blood pressure, by and large, is useful because, of course, it allows involvement of the patient in the treatment regimen, and this has been proven to be good for compliance, for adherence to treatment. But there is a fraction of, a number of patients who become obsessed with the procedure, and they continue to measure blood pressure hour after hour, minute after minute. If blood pressure is high, they measure it a second time because they hope that the second measurement will be normal. If it is normal, they want confirmation. And so I'm sure that you have the same experience. That is that patients spending the whole day measuring blood pressure. And in this case, of course, an authoritative doctor should stop home blood pressure measurement, which is not easy in those cases.
We enjoyed the flashes of expertise during the course. Thank you very much, Dr. Mancia.
Thank you.